hang on just for a few minutes. We'll get started here with our Crisis Residential Association presentation shortly. Welcome. We'll get started shortly. Welcome. We'll get started shortly. Welcome, folks. We really appreciate you attending. Just hang on. We'll get started shortly. Welcome. We're glad to have you. We'll get started shortly. Welcome. We're going to get started shortly.
Good afternoon to some of you. Good morning to others. Welcome to the Crisis Residential Association webinar, special feature for MHCA members. My name is Travis Atkinson, and we're glad that you're joining us. I'd like to start with a story about a person named Jim. So Jim grew up in North Carolina in the 1960s. When he was a teenager, he started applying to colleges, but he started to descend into a depression. His grades collapsed. He was sleeping about 20 hours a day, and he felt that he was living a life that he just was not able to lead. So in the mid-60s, he was committed to McLean Hospital in Massachusetts, and he began to get a sense of order and routine, and started to feel more like himself. So he had access to really high quality treatment and a team that listened to him and knew how to help him with what he was going through. He later earned his diploma while he was at the hospital, and referred to his time in the hospital as a lifesaver. He said he felt like a pardon or a reprieve, and was able to go on to pursue the things that he loved. He was also inspired to pursue some of his artistic endeavors while he was in the hospital, writing songs like Fire and Rain and Carolina in My Mind, and would go on to become one of the most prolific folk singer-songwriters in U.S. history. This person's name is James Taylor. Many of you know his music, and many of you probably also know other musicians and artists and prominent figures in our country's history who have gone through similar moments of despair or experiences. And what's been really helpful for people like this is that they have access to good quality services when they're experiencing a behavioral health crisis, that they have choice in the services that they receive, and that they're receiving treatment that works. And all of these are values that the Crisis Residential Association shares, that we are excited to talk with you about today on this webinar.
Well, thank you, Travis, for such a wonderful story, and I think it's really an inspiration to us. My name's Carrie Wirick. I'm going to be one of the moderators today. I'm the committee chair and a board member of the Crisis Residential Association. Joining me is Travis Atkinson. He's the president of our Crisis Residential Association, and Jaime Brewer, secretary of the Crisis Residential Association.
Just to give you all a brief outline of what our goals are for today, we're going to talk a little bit about why the CRA is needed, how we align with other initiatives, and how you all as CEOs and C-suite leaders can really take advantage of what we have to offer in order to better your organizations. We're going to discuss a little bit of the handbook that we've developed for best practices and talk about the future of Crisis Residential Association and, again, how that will apply to you and your organizations. Finally, we'll have some time at the end to answer any questions that you all might have.
So the Crisis Residential Association is a not-for-profit 501c3 membership-based organization. So we exist to advocate for comprehensive, dignified, and sustainable services for those experiencing a mental health crisis. Our mission statement is that we exist to support the operational and clinical functions of crisis residential programs around the world. Rooted in the values of empathy, recovery, and continuous improvement, the association seeks to connect providers with the best ideas in behavioral health treatment to transform the way people receive mental health care. For those of you who work at organizations that provide crisis services, you know sometimes how elusive the best practices and the innovations can be to discover. Sometimes you might be creating those innovations, or sometimes you might be hearing about them from fellow providers in your state or fellow MHCA members. But it can happen in kind of a piecemeal way, or a way that doesn't always come with consistency. So CRA is the first organization that is exclusively focused on crisis residential providers, of which there's about 600 to 700 in the United States. So we're going to pull up a little bit more information here about our organization. So as I said, we're membership-based. We were formed in the end of 2018, so we're a very new organization. We started because a group of current and past providers of these crisis residential or crisis stabilization services got together in 2016, and we formed a work group to talk about best practices and what it would look like if we could start to document some of these ideas around behavioral health crisis services specific to this level of care. So for the next 12 to 15 months, we facilitated, sorry, if you could go back just for a minute, we facilitated a work group to talk about what these best practices are. Like what are the good staffing models? What are the good clinical interventions? What are the finance models that really make these programs work? These are things that each of us might have known in pockets, or might have known a few things about, but really have not been able to have these conversations on a national stage or at a national level. So the results of that work group was a best practices handbook, which Jaime's going to talk about in a little bit. But after we completed that work group, we had some momentum, and we said, what if we hosted a conference to talk about these things? And so in October of 2018, we hosted the Alternatives to Hospitalization Crisis Residential Conference. This was the first conference of its kind to talk specifically about these alternatives and about how we can move the dialogue forward on best practices and on how to do this work really well. So I want to just spend a brief moment talking about what a comprehensive crisis continuum looks like. Some of you operate many services within this continuum, but there's not been, up until recently, there's not been a lot of focus around the importance of these services. Typically and traditionally, going back earlier than 10 or 15 years ago, people have accessed behavioral health crisis services through the medical emergency services. So things like 911 and EMS and emergency departments all the way into the psychiatric hospital. A comprehensive continuum really tries to focus on how can we use the least restrictive settings to serve people, and how can we focus on diversion at every level of the continuum. So replacing 911 call centers as the solution for behavioral health crises with a crisis call center, replacing just a police officer visit with a complement of trained officers in CIT and crisis intervention training with mobile crisis workers to meet people out in the community where their crisis is taking place, and then moving them into one of these levels of care. Whether it's a peer respite facility for people who are experiencing emotional distress and just need some reprieve from what they're going through, to a 23-hour unit, which might serve as an alternative to going to the emergency department for a person with a psychiatric emergency, to this crisis residential model. So we want to focus a little bit more in right now on what that crisis residential model means exactly. So next slide. So crisis residential services are any service that is a multi-day length of stay, that has clinical staffing, usually nurses, let's say 4 to 8 hours a day, or maybe in some cases 12 to 16 hours a day, a psychiatrist who's on site a few days a week, direct support professionals 24 hours a day, and services in homes that are usually in size between 6 and 16 beds. In these services often happen in less clinical settings, so they can be literally in a home, in let's say a ranch style home in a neighborhood. They can also happen within a clinic or within a continuum of other services that exist on a campus, but they have less of a medical model feel and more of a focus on recovery oriented care. What's great about these services is that there is over 35 years of research demonstrating these outcomes when you compare a crisis residential program or a crisis residential unit to psychiatric hospitals. And those outcomes include those results include better clinical outcomes, a higher client satisfaction, and lower cost. And there's almost 24 of these articles. So it's not just a random experience or one study that happened, but really going back to the 1970s, these programs have really served to be beneficial. And for those of you that operate these programs, I'm sure that you know about their efficacy and their importance in your treatment continuum.
Let me take this moment to encourage folks, if you have questions about what Travis is talking about, there's a question box on the right-hand side of your screen under the orange arrow, and you're welcome to type them in at any point.
Thank you, Carrie. So as Travis mentioned, crisis residential units and programs have been in operation for around 35 years. However, historically, psychiatric inpatient facilities and hospitals have really controlled the narrative around bed-based services. So we hear a lot about a lack of psychiatric beds in states and that it is causing a crisis in treatment for our individuals who need a higher level of care. However, more recently, a lot of communities and states and governments have begun to see the necessity of crisis stabilization units, crisis respite units, things of that nature, and have started to put a little bit more focus into developing those programs within communities and within states. The Crisis Residential Association then really is forming, and our goal is to assist those programs in getting the advocacy that they need within their states and within their communities, providing the resources, the research, the best practices that can help a program to stay sustainable and to show that efficacy to funders, and to really be inclusive of different types of providers and payers and ways that these services can be administered and take place within communities. So many residential associations for many years operated just as an island. There wasn't many resources for them to reach out and ask questions of other types of similar programs. And I can tell you from personal experience, having the Crisis Residential Association and being linked to other members has really been a benefit for the programs that I oversee at my organization. So, for example, I know of the state of Colorado, in the last 4 or 5 years recently really expanded its crisis services, which included crisis stabilization units and crisis respite units. And as I oversee those programs at my organization, I have been able to reach out to listservs and ask, what codes do you bill for Medicaid? How have other centers been able to contract with commercial insurance to stay sustainable? How do other centers do their drug disposal and bag search procedures when individuals come into their units? So for you all as CEOs and C-suite leaders, this type of information is really important to be able to get to your program managers, your program directors, in order to develop a program that is sustainable and that really delivers the best services to consumers and clients. Additionally, as CEOs and C-suite leaders, when you all are talking with your state lawmakers, with your advocacy groups that help you with your programming and things, it's really helpful to have the statistics and the research that backs up and shows why these types of programs are so successful, why these types of programs will save other payer sources money, and why they should contract with you versus the local psychiatric hospital. So this is another great tool for individuals at your level to really be able to have in your tool belt to advocate for your programs and, again, make them more sustainable. Another great example of using the CRA for success is when you're starting a program initially, which again is another trend that's occurring across our nation. When you are starting up a program, if you're really trying to just start from scratch and completely invent the wheel on your own, it can be challenging and you'll encounter bumps in the road. However, if you can take what's already been done and use that knowledge to start up a program, that's really going to give you a great kickstart and put you on the right path to success in your program and for your clients. Travis also mentioned the best practices handbook that was developed in the beginning stages as we were kind of forming our organization and getting this group of individuals together. And so I want to just give you guys a little bit more information on that. You can use this handbook and find it for free on our website. And again, it's a great resource if you are starting out or even if you are an existing program to kind of measure up to what other programs have and what they do across the nation. So included in this toolkit is an overview of the scope and function of various crisis residential programs throughout the nation, different philosophies of care, how staffing patterns are done at different agencies, what kind of staff are there. Do you have nurses 24/7? Do you have nurses that visit once a week? Do you have NPs? Do you have psychiatrists, mental health techs, peer specialists? Right? It'll give you a really good idea of what goes into a good program. We talk a little bit in that handbook about how you do admissions, discharges, how you get referrals, a brief overview of various funding sources, again, that most commonly are found in these types of organizations and programs throughout the U.S. As you see here on the slide, this handbook had over 80 different contributors from across the U.S. and also a little bit of an international perspective with some participation from England and the Dominican Republic. So this is just one example of a way that the Crisis Residential Association is looking to put together best practices and tools for you all to use in your programs moving forward.
And Jaime, if I could just add to that a little bit, a couple cool additions in the handbook are some vignettes about really excellent things that we found some of these crisis residential programs doing, such as creating a quilt of like encouraging messages from people who were discharging from the program, and those quilts would be compiled and then put on the walls of the program so that people could learn and gain some wisdom from other people who had gone through there. We also talked about how to start a garden, a community garden at your center, and that people could engage in or collect grow vegetables from. And then we also talked about like how to set up a postcard of like follow-up, like aftercare follow-up to see how people are doing or just to provide some encouragement. The other thing that we want to touch on, and we'll go into this in the future direction section of this discussion, but we're really trying to bring some consistency to the words that we use to describe these programs. So when we say crisis residential, depending on what state you're in, we might be talking about a crisis stabilization unit, a residential crisis facility. In North Carolina, they're called facility-based crisis programs. So these programs go by a lot of different names, and they can often mean the same things. So we're doing some work right now on the back end on taxonomy so that we can start to use common language when we're talking about what we mean in these programs.
And Travis, that's a really great point. The other thing that I would just expand on as that goes is, as we reference, our crisis residential programs, your program might not even have the name crisis in it. There are some programs that are run that are, a hospital alternative program, or maybe a name that's something, at our agency we have stages, and those are considered, step downs from hospitalization sometimes, but are also used as interventions to prevent an individual from getting up to that level of care. So as you are thinking about crisis residential, really be thinking about the purpose of your programs or programs that you may be looking to open and start, and know that it doesn't have to have the name crisis in it for these tools and these things to apply.
Okay, well, our Crisis Residential Association has several committees because we're all busy working on things to promote and understand crisis residential services even better. So we've got the conference committee that planned our last year's conference in San Diego and working on this year's conference in Grand Rapids. And I have to say, from the San Diego conference, it was so energizing and so validating to connect with others who are doing these services. We are so isolated because there aren't many crisis providers in one region of the state. And so it's so wonderful to be able to connect with others. I'm chair of the Training and Education Committee, and we promote webinars that are on a regular basis from thought leaders about topics that are pertinent to the crisis residential field, and I'll be talking more a little bit more about that. We've got a marketing and communications department that works on social media and getting our brand out there so that people can reach us. They know who we are. They know how to find out more information. And then we have our membership committee that is working on actually driving those members and building us up so that we're a vital, active trade association that will be around for a while. Something else that we work on at times are there could be political, legislative issues that we want to promote the idea of recovery, trauma-informed care with this very, very vulnerable population. So we work on that too.
And Carrie, if I could just add to that, that membership, our membership structure is set up to facilitate for organizations, for individuals, but also for people with lived experience and for students. Because we really are trying to take an inclusive approach to our organization and make sure that that we're not omitting anyone from the conversations or from people who are passionate about being involved in these services. And there's more information about membership on our website, which we'll get to later, but that we've really tried to set this up to be reasonable, but also to be a valuable addition for organizations.
Absolutely, and we recognize the value of diversity, and that's really the value of the association, because we want to break through those silos where we've been functioning by ourselves for so long. And so hearing other points of view from different folks, from folks with lived experience, from a more medical perspective, a more institutional perspective, or a more home-based perspective, it enriches the whole experience. Mm-hmm. So our webinars that we've done so far this year have been fantastic. We get about 150 to 200 registrations, and they're all recorded so that individuals can look at them later on. They're 1-hour webinars, and we've covered some really great topics with some thought leaders out there. The first one was on zero suicide in a crisis residential setting. This was a very fascinating, dynamic webinar by Dr. Chuck Browning. He's the medical director of RI International, and it was really nice to apply zero suicide practices to crisis residential. And as we know, zero suicide is the way to provide a structured quality improvement model to eliminate kind of loopholes where the client can feel forgotten, or where the client can feel like their thoughts of wanting to die are not addressed. So we really want to be at the top of the field in terms of understanding what actually reduces suicide, and zero suicide is one of them. So we're real excited to hear from Dr. Browning on that. Our second one in July was on the issue of physical restraint. Some of our crisis residential units use physical restraint, some of them don't. And so it was a really dynamic discussion about how to move, in his case, how to move from a residential facility that used restraint with children to one who worked very hard to eliminate that. So a lot of trauma-informed care themes go into this, and it was a very dynamic discussion on that one. And then just a few days ago, we had Rania Hassan from Rosecrans sharing about engaging and retaining crisis residential staff and how to lead with intention. This is a field with a high burnout rate. What we experience is people at their worst, and when they're doing better, they might not come back to see us. So when we are working with this population, we are inundated with folks experiencing such horrible situations and emotionally wrenching situations. It can be really, really easy to burn out. So Rania's presentation was fascinating about how to lead with intention, how to make the culture and promoting resiliency, self-care, and trauma-informed care, how to promote that culture from your leaders down to your line staff, and to foster that communication both from leadership down and from the line staff back up, and how to make it purposeful and intentional. And we got some fantastic feedback on all of these, but especially that one, because I think we all are looking at how very, very expensive turnover is and how much we are competing with other agencies or hospitals that might be able to pay more, and how very, very valuable that those special individuals that can really connect with clients and help them feel calmer and feel safe, those individuals are really important for us to retain. So we had a great time at that webinar, and we're going to continue to be doing them. And they're offered free to our members. We're really working on developing this so it's a very active community where we can feel like we are connecting with each other in the community, even in between our live annual conferences.
So we see a number of future opportunities for the Crisis Residential Association, one of which is engaging in some data collection and benchmarking around crisis residential services. There are no national standards pertaining to crisis services, to the data, to the outcomes, to what exactly should be done to measure and assess these programs. And we really see that CRA can provide a leadership opportunity with the hundreds of providers across the country in leading these discussions and doing some data collection. The best time to collect data or to set benchmarks is when you're not being asked to. When a funder comes in and says, you're going to start measuring this next month, that can really shock the system. But when providers are prepared and have the resources ready to engage in those discussions before they're urgent, we really think that creates a competitive advantage for the providers in those discussions. Another opportunity is to develop national standards and accreditation of crisis residential programs. Oftentimes these programs, for example in Michigan, are forced into the guidelines that surround adult foster care residential services. And because they serve as a temporary home or a brief respite, but not really as long-term residential services, they don't always quite fit in those parameters. So starting to identify what exactly makes these services work and how can we provide a level of quality assurance across the country that programs meet certain expectations. A third opportunity is to advocate for competitive rates and other sustainability factors. I think Jaime alluded to this earlier, but there are unsung stories of crisis programs that go under. For whatever reason, they're not financially sustainable. They don't get enough referrals. There's changes in leadership at the payer level, and they might not understand the value of the services, whatever it is. But we really believe that a strong crisis continuum in any community includes an alternative to psychiatric hospitalization that is crisis residential services. And the last opportunity we have listed here is to advocate for best practices in crisis coordination. That crisis residential programs should really be included in the conversation around statewide bed registries, that they should be rewarded for the cost savings that they're able to actualize by diverting people from the psychiatric hospital, sometimes from jail, sometimes from the emergency departments, that really if they're saving people money and they're producing better outcomes, then the payment arrangement should really reflect those successes. Here are a few testimonials of our members. We'll give you a minute to read these, but as you can see, we're finding a lot of our members are just very much activated by their opportunity to engage in the organization, to make a difference, to connect with their colleagues, and to just be a part of something bigger than themselves. We see it bringing a lot of hope to organizations and to leadership in the crisis services, and to start to imagine opportunities for ways to provide services even better. So we'll give you just a minute to look at a few of these testimonials. Great, and we'll move on to the next slide.
So as we wrap up, we again want to share how excited we are to be offering the second annual Crisis Residential Conference coming up at the beginning of this October in Grand Rapids, Michigan. We have some great speakers lined up, including Dr. William Beecroft, who is the Medical Director of Behavioral Health at Blue Cross Blue Shield. And he's going to be talking a little bit about how you can work with commercial payers and contract with them for your programs. Dr. Deborah Penals is the Medical Director of Behavioral Health and Forensic Programs at the Michigan Department of Health and Human Services. And she is just going to be talking a little bit about crisis residential and advocating for recovery-oriented services through leadership and policy. And finally, Marilyn Kresge-Wolf, who co-founded the very first community-based residential psychiatric crisis center on the East Coast, which is Crossing Place. So she's going to have the opportunity to talk about what that experience was like, bringing that type of program that we are now more familiar with to the East Coast for the first time, and how that has really been an impact on individuals that are experiencing crisis and needing that level of care there. So there's still plenty of time to register if you're interested in joining us. You can access more information on our website, www.crisisresidentialnetwork.com, under our conference tab. We are also going to be providing a tour of one of the local crisis residential facilities, which is very cool. I got the opportunity to tour one in San Diego at our conference last year, and it was really neat to get to see how another program looks and operates. So again, if you are interested, still plenty of time to register and join us for this conference.
And if I can add, there's also pre-conference seminars. There's a assessment and management of suicide risk, which is a zero suicide training, and there's also a management training, which is really good, because a lot of times our managers in crisis residential services are fantastic social workers or counselors or nurses who've been promoted, but they may need some extra oomph from some management training too. So we're really pleased to offer those pre-conference trainings the day before. And now what I'd like to do is open it up to questions. The first question that's come in is, if I can't send my people to the conference, does it still make sense to belong to the Crisis Residential Association? Travis, do you want to take that one?
Yeah, I'd love to. To answer that question, I would say absolutely yes. While we certainly value the conference experience for our members, we try to offer a lot of other benefits besides just the conference. So Carrie talked about the webinars, which have been open to the public, but will become an exclusive membership benefit starting in after the conference in October or November. And we have a listserv, which will be membership based as well, to kind of bounce ideas off of each other, or try, hey, we need an intake form, like we have a question about we're trying to develop a new intake form. We really see the association is providing value to providers who are interested in starting to provide these services for the first time. So for example, one of our members joined as early as membership was open, so just maybe 4 or 5 months ago, and they just opened their program yesterday. So they've been able to take in information from the work group, from the toolkit, as well as from a dialogue that they're a part of as members of the association. We send out a periodic newsletter to our members as well, and we're going to start taking some more efforts around policy advocacy at a national level, whether it's around crisis bed registries or making sure that these programs are included in the conversation. So a number of benefits that we're trying to offer to members that go well beyond just the conference.
That's great. Thank you so much for that. I also have a question about, is this webinar being recorded? And yes, it will. It is being recorded, and the recording will be made available to you. The next question I have is, we have someone who's interested in more articles about the cost effectiveness of crisis residential services. And I don't know, Travis or Jaime, if you have.
Yeah, so TBD Solutions, which is the organization that I work for, we published just a basic review of articles, research articles on these services last year. So if you go to tbdsolutions.com and you click on the papers and presentations, you can download that for free. I think it's called Crisis Research Summary, and that goes back from the 70s up until about 2012 or 2013. And several of those research articles reference cost savings. You'll also find that information in the Crisis Residential Handbook, which you can download as well.
Excellent. Okay, what I'd like to do now is I'm going to take everyone off mute so that you can just speak up and ask me, Travis, or Jaime any questions that you have to just ask directly. So I'm going to take you off mute. So if you're not, if your microphone is off, you won't be heard. So.
Carrie, as we're waiting for questions, I just wanted to mention one other thing. First of all, thanks to Dale Shreve and the executive leadership team at MHCA for having us. We really were glad to find this opportunity for synergy between these organizations. And there's also a lot of overlap between the members of MHCA at being providers of these crisis residential services. So
sorry, we
Carrie,
lost
can you hear me?
Yeah.
That's okay.
You're back.
I was just going to say, organizations like Burke out of Texas and Burt Nash from Kansas and the Harris Center in Texas all operate these services, and so it really provides this great platform to support that service line within those organizations. And we also have MHCA members who have already become organizational members, like Hope Network in Michigan and Centerstone in Kentucky. So, for those of you that operate crisis services or are thinking of operating crisis services, we really think that this is intended to be a helpful platform for you and your team.
Okay. I don't see other questions coming in. And I don't see folks. Yeah?
I was just going to say, if not, we can go ahead and wrap up.
Okay. Well, thank you, folks, so much for participating in this webinar. We hope you learned something about the Crisis Residential Association, and we also hope that you learned a little bit more about Crisis Residential Services and how stronger together we can become. Thank you so much.